So a little bit of background history on pelvic venous disorders. We popularly know as PCS, and in this presentation, I've kept it as PCS, but it's interchangeable with PEVD or pelvic venous disorders, as they are now known as. In the mid-19th century, the association between chronic pelvic pain and the presence of varicose veins in the uterovarian plexus was noted by Richer, who also described the presence of pelvic varices. So awareness of this disease has been since the mid-1850s. In 1949, Taylor first described pelvic venous enlargement as a cause of chronic pelvic pain. And the first treatment of pelvic congestion syndrome by embolization was done by Edwards et al., an interventional radiologist, in 1993. So we're 30 years into the treatment of this disease process now. As far as the definition and prevalence of pelvic congestion syndrome, the recent definition, previously the layman's definition was chronic pelvic pain greater than 6 months duration, but they made it a little more comprehensive in this vein term transatlantic interdisciplinary consensus document, which described PCS as chronic symptoms, which may include pelvic pain, perineal heaviness, urgency of micturition, postcoital pain caused by ovarian and or pelvic vein reflux and or obstruction, and which may be associated with vulvar, perineal, and or lower extremity varices. So essentially the etiology and the pathophysiology has all been included in this definition of PCS or pelvic venous disorders. It has been reported in various epidemiological studies as many as 39% of women experience chronic pelvic pain at some time in their life. And in this group of patients in whom there are no other apparent causes of pelvic pain, an estimated 30% have pelvic venous insufficiency. And ovarian vein dilatation is seen in 10% of women, up to 60% of whom may develop a PCS. An additional 15% have PCS along with another pelvic pathology, and these are this cohort of patients who will not have significant improvement with just treatment of the venous aspect of pelvic congestion syndrome and may need other subspecialty involvements to get rid of their symptoms completely. Pathophysiology of pelvic congestion syndrome. This most commonly affects the premenopausal multiparous females in the reproductive age group of 20 to 45 years. And incidence is strongly related with the numbers of pregnancies. Gravida 2 or more is considered a risk factor, although we treat patients, we've seen patients less than 20 and greater than 45 because we see a lot of patients with pelvic pain, but this is the majority of presentation. Symptoms which are associated with PCS presumably arise from pelvic venous hypertension with distension of the periuterine venous plexus. Now, what's the pathophysiology behind the pelvic venous hypertension, reflux versus obstruction? We'll expound on that going forward in this presentation. This is related, the development of pelvic venous hypertension is related to several hormonal, genetic, and hemodynamic factors, which are associated with venous dilatation, decreased elasticity of the vein wall, and ultimately valvular incompetence. And it also has been classically associated with the incompetence of the ovarian veins, and the symptoms can result from primary internal iliac vein reflux or from a compressive pathology. So it's reflux versus obstructive pathologies. Are they two interrelated? We'll see. So pathogenesis of pelvic congestion syndrome, basically how you get to the point where the pelvic venous hypertension becomes significant that it starts to cause symptoms. We look at two aspects of pelvic congestion: primary pelvic congestion syndrome and secondary pelvic congestion syndrome. Primary pelvic congestion syndrome involves increase in venous capacity, and these are the conditions which can affect that. Pregnancy is the most common, and then of course the effect of estrogens. And secondary pelvic congestion syndrome is because of an obstructive anatomic anomaly, May-Turner syndrome, retroaortic left renal vein, nutcracker phenomenon, and we'll talk about this in the subsequent slides. So this is the primary PCS pathogenesis. Basically, the endocrine factors, estrogen causes increased nitric oxide production, which then leads to smooth muscle relaxation, as we all know. And that leads to periuterine and ovarian vein dilatation, which will cause reflux because of eventual valvular dysfunction and development of pelvic varicosities. Progesterone, on the other hand, reduces the venous tone, and then it also leads to periuterine and ovarian vein dilatation, leading to reflux and development of varicosities. Pregnancy, there's a twofold mechanism. There is increased vascularity because of the overall physiology, and that causes a 60 times increased blood flow, which then can lead to periuterine and ovarian vein dilatation and valvular dysfunction and development of varicosities, as well as the compression of the inferior vena cava by the gravid uterus can lead to periuterine and ovarian vein dilatation, reflux in those veins, and development of pelvic varicosities. So all of this eventually leads to pelvic venous hypertension, which then causes symptom manifestation. The compressive pathologies, as we talked about, the May-Turner syndrome is very focal compression of the left common iliac vein by the right common iliac artery. You can see that in the first picture. The blue vessel is the vein, and the pink or the red one is the artery. And this commonly happens when there is compression between the fourth or the fifth lumbosacral spine, and the artery lies on top, and the vein gets pinched between the artery and the vein. Artery and the bone. And May-Turner is very specific, or for this point compression, although we see compression in other areas lower down in the common iliac or also in the external iliac, which happens when the internal iliac artery crosses the external iliac vein. Can happen on the left side, can happen on the right side. And there's a cross-sectional picture which shows the squished or slit-like artery between the, slit-like vein between the artery and the bone. And when we put the stent in, it's propped up now nice and round. That's how we treat May-Turner's, or iliac vein compression, as we call it. The next picture shows the normal anatomy of the renal vein in position in relation to the superior mesenteric artery and the aorta. But when the angulation becomes more acute of the SMA, it can squish the left renal vein between itself and the aorta, and that can lead to what we call nutcracker phenomenon, where there is dilatation of the ovarian vein. Patients present with epigastric vein or flank pain with hematuria, which may be microscopic or frank. So these are the obstructive pathologies which can lead to pelvic venous hypertension. Also retroperitoneal masses can cause or significant adhesions which form when patients have had multiple abdominal surgeries. All of that can cause compressive pathologies to develop or compressive symptoms to develop, and that can lead to pelvic venous hypertension. The PCS may be associated with lower extremity varicose veins, either in a typical axial saphenous distribution or in atypical locations, including the vulva, the perineum, and the posterior thigh, what we call the escape veins. Such varices arise from the development of venous reflux in the distal tributaries of the internal iliac veins, with transmission of venous pressure through the escape points in the pelvic floor to the lower extremity veins. So the perineal varicosities, which is the connection between the internal and external pudendal veins, cause inner thigh and posterior labial varicose veins to develop. Inguinal cause groin and labial varicose veins, and also you can have gluteal varicosities and varicosities along the trachea of the sciatic nerve, which can mimic sciatica, and is in fact because of increased pressure and development of these varicose veins along the tract of the sciatic nerve. So these are the escape points in the pelvic region. The obturator, O is obturator, inguinal as I, P, pudendal, and gluteal. This is where the escape veins develop and then can communicate with the lower extremity veins. So these are very pathognomic of people who have pelvic congestion syndrome, and it behooves us to do a complete physical exam of these patients, especially the gluteal area, because they're not able to sometimes see that on their own when they come for evaluation for pelvic congestion syndrome or pelvic pain. As far as the structural changes in PCS, anatomic studies have shown that approximately 13 to 15% of women have no valves in the left ovarian vein. And autopsy series also have shown that the upper portion of ovarian veins, valves were absent on the right in 6% and on the left in 15%. So venous hypertension in these pelvic veins increases the expression of matrix metalloproteinases, which are enzymes which degrade the underlying endothelium and the smooth muscle. And these changes impair the ability of the veins to constrict and relax, leading to increased venous pressure, which further promotes endothelial cell injury by triggering leukocyte response and inflammation, resulting in chronic venous distension and reflux. The histology, interestingly, of the pelvic varicosities is similar to that of the varicose veins elsewhere, which includes fibrosis of the tunica media and the intima, as well as muscular hypertrophy and proliferation of the capillary endothelium. So also what they've noticed that women who have pelvic congestion syndrome tend to have a larger uterus with more cystic changes in the ovaries than healthy women because of congestion and estrogen overstimulation. And this is a physiological fact that during a normal menstrual cycle, the ovarian veins are exposed to nearly 100-fold concentration of estrone and estradiol compared with the peripheral plasma, probably because of the proximity of these veins next to the ovaries. Ultrasound studies have shown a significant increase in uterine thickness and size in people who present with, or patients who present with pelvic congestion. So the diagnosis involves clinical evaluation and then investigative modalities. Clinically, these patients present between 20 to 45 years of age, as we talked about in the past, more common in multiparous females. The pelvic pain is described as typically dull and aching in nature, non-cyclical. It can be exacerbated by postural changes, walking, and sexual intercourse, and also during menstruation. Dyspareunia, which is defined as pain during or after coitus with 6 or more points by VAS, usually radiating out to the anus and have variable duration up to 24 hours. So it can last, the symptoms can last anywhere from few minutes post-act to up to a day or 2 days post-intercourse. More seldom, a patient with pelvic varicosities may present with renal colic due to urethral compression by a dilated ovarian vein. So this is known as ovarian vein syndrome. Now, physical examination, we normally don't do that because, you know, it's, but this is what, you know, most of the gynecologists have do it when the patients come to them initially for evaluation of pelvic congestion, cervical motion tenderness. However, we can easily do the point tenderness of the ovaries. And the way to do that is to draw an imaginary line from the anterior superior iliac spine to the umbilicus and look at the proximal and mid-third junction. And if you press there and there is point tenderness, that kind of points to the ovaries. So it's called ovarian point tenderness. It's a combination of post-coital ache and ovarian point tenderness is reported to be 94% sensitive and 77% specific for pelvic venous insufficiency when confirmed by venography. And as I said in the previous slides, it's important to evaluate varicose vein network, which may be present on the perineal, the vulval, the gluteal or posterior thigh areas. The vulval varicosities develop because of reflux in the left and the right ovarian and the pudendal obturator veins, whereas the perineal, gluteal, and posterior thigh varicosities mostly generated by the reflux from the internal iliac vein. And also there is a strong association between hemorrhoids and internal iliac vein reflux. So non-invasive testing, the primary goal and utility of the ultrasound, the MR, magnetic resonance imaging, as well as CT scan in the workup of pelvic venous insufficiency is to exclude a concurrent pathological pelvic process, especially malignancy. So this is one thing we don't want to miss in people who present with chronic pelvic pain. Although most of these patients who come to us have had a comprehensive evaluation and workup done by the gynecologist, urogynecology, GI, GU, every possible what you call modality has been looked at to try to explain their symptoms. The sensitivity of these diagnostic, non-invasive diagnostic methods is as low as 59% for MRI, 20% for ultrasound, and 13% for CT. So transvaginal ultrasound more correctly shows enlargement and congestion of pelvic veins. However, transabdominal ultrasound has a greater diagnostic value because of the direct visualization of the left ovarian vein. So we can measure the diameters transabdominally. We can look at the reflux pattern in the left ovarian vein. So, and this is what we normally use in our patients who come to us for chronic pelvic pain. They will have a transabdominal ultrasound to look for reflux in the ovarian veins, the periuterine plexus, as well as the compression of the iliac veins based on the sizes and the velocities and flow patterns. So ovarian vein diameter of 6 millimeters or more on transabdominal ultrasonography has been reported to have a 96% positive predictive value for pelvic varices. And again, the transabdominal ultrasound in the right hands gives us a lot of information about what's going on in the vasculature in the pelvic area. So the other thing we look for is the pelvic venous plexus. And the normal pelvic venous plexus is one or two straight tubular structures with a diameter of less than 5 millimeters. However, when you see circular or linear venous structures with diameters greater than 5 millimeters, it is indicative of pelvic varicosities. And the color flow Doppler will show reverse caudal blood flow in the ovarian veins. Sometimes we are able to visualize dilated arcuate veins crossing the myometrium. And of course, the atypical varicose veins located on the posterior and lateral aspect of the thigh are quite pathognomic for pelvic venous insufficiency, and these can also cause non-saphenofemoral reflux in the groin. So this is an ultrasound image of a patient who has significant pelvic venous insufficiency. The BMOR above and then the color flow Doppler below. Now, typically the best images obtained when the patient is standing. We normally do a supine transabdominal, and if there is a suspicion, we'll do a translabial. The techs will do a translabial, evaluation to look for these pelvic varices. And what we see is tortuous pelvic veins diameter of greater than 6 millimeters. And then there's slow blood flow and reverse caudal flow, which is seen in the bottom picture. Then there's dilated arcuate veins that communicate between bilateral pelvic varicose veins. And of course, the Doppler waveforms change in these patients. And this is an example of a CT venogram showing dilated ovarian veins bilaterally, as well as the asterisks. And those are the curved arrows, left and the right. And then the asterisk shows the filling of the parauterine and the periuterine veins. Pooling of blood in those segments suggestive of patients with pelvic venous disease. And this is an MR venogram. On the left, you see the retrograde flow in the dilated left ovarian vein, which arises from the left renal vein. The right ovarian vein, 85 to 90% of the times, arises directly from the IVC. And then we also see the early drainage in the left iliac vein, which results in, again, venous hypertension. And sometimes we are able to follow this communication with the escape veins if we, scan them lower enough. And then, of course, the left parametrial varices with crossover to the right side. On the right side is an image of MR venogram image of a patient with May Turner. You can see the wider tube is the inferior vena cava, the narrower is the aorta, the right common iliac arteries crossing the left common iliac vein, and right at the junction on the right picture, you see absence of contrast, which is where the compression is happening, which causes decreased contrast flow through that area. So this is very classic for May Turner syndrome or left common iliac vein compression. Now, this is a A good tool to have, again, laparoscopy. Most of these patients who come to us for especially gynecologic referrals have had a laparoscopy, and that's what the physician finds on their on the procedure, that there's dilated veins suggestive of pelvic congestion. So this becomes a source of our consults. So the sensitivity of laparoscopy is about 40% for diagnosis of pelvic congestion syndrome. So patients with chronic pelvic pain, to rule out endometriosis, they routinely undergo laparoscopic procedures, and if these dilated veins are seen, then that makes the diagnosis a little more significant. Now, of course, the gold standard is venography for diagnostic testing. It is an invasive procedure. The ovarian veins are cannulated either from the internal jugular vein route or the common femoral vein route. The right-sided ovarian vein is much more amenable to an IJ cannulation by the IJ access point, and the left left ovarian vein can easily be, most of the times we can be easily cannulated from the femoral route. So we selectively put the catheter inside the ovarian vein and inject contrast. We look at reflux, which is basically contrast retention for greater than 20 seconds. We look at the diameters. Greater than 5 millimeters is considered significant. And then also uterine venous engorgement and crossover of the pelvic veins across the midline, filming. And sometimes if you stay long enough, in certain patients, you can see the filling of the vulvovaginal and thigh varicoses, but you have to stay on the floor for long enough and track with the scan it down all the way into the lower part of the pelvis and the upper thigh area to see that. Some physicians will also routinely do a balloon occlusion venography of the internal iliac vein to opacify the escape veins. So it all depends upon your focus of interest. And for the common iliac vein pathology, diagnostic venography is routinely performed. Again, this is a part of the evaluation for patients who present with chronic pelvic pain. And you can see there is haziness, or in this picture, there's the cannulas are inserted in the common femoral veins. Then there is a pacification of the external iliac vein, common iliac vein up top, and then becomes the inferior vena cava with the right and then the left common iliac vein. And then where the left common iliac vein is joining the IVC, you see there is haziness or lack of contrast, which is basically the flattening of the LCIV, or what we call the pancake effect, because the right common iliac artery is crossing over and is preventing the contrast to fill appropriately because of the compression that is happening. And that causes the blood to go back into the reflux into the hypogastric or the internal iliac vein, which is dilated and refluxing, and then you see the crossover happening to the right side. So all of that can be visualized very well with diagnostic venography. However, to assess for the compression, we have to use an IVUS, which is the gold standard for iliac vein compression evaluation. And there's significant narrowing on the left picture of the left common iliac vein compared to the normal reference segment. So we compare the compressed segment to the normal segment and calculate the reduction in area or compressed segment percentage stenosis. And based on those numbers, and the patient's clinical presentation, the next step is to intervene with a balloon and or a stent. So as far as the differential diagnosis is concerned, I mean, this is just a small list of what patients who present with chronic pelvic pain should have been looked at and evaluated for. Most of these patients, I would say 90 to 95% of the patients who present to us have had this workup done to rule out fibroids, adenomyosis, endometriosis, pelvic inflammatory disease, ovarian and fallopian tube diseases, pelvic tumors, cystitis, inflammatory bowel diseases, adhesions from previous surgeries, pelvic arterial venous malformations, portal hypertension, and then, I haven't mentioned the myofascial pelvic, syndrome, There is with the pelvic floor, what you call weakness and muscular and neurological issues, pudendal neuralgias. There's a host of this, like a host, as I said, multiple neurological and musculoskeletal etiologies that have now been slowly being discovered, and then of course trying to find treatments for the same, which can cause patients to present with chronic pelvic pain. And some psychosocial factors can play into patients presenting with chronic pelvic pain, especially sexual abuse during adolescence and as teenagers can lead to patients having chronic pelvic pain without any real anatomical or etiology being discovered. So all of these conditions have to be evaluated appropriately and treated before we jump onto the vascular causes for chronic pelvic pain. So a little bit about the SVP classification. This, like in for the lower extremity venous disease, we have the SEEP classification, which basically talks about the clinical presentation, etiology, anatomy, and pathophysiology. And SEEP will, across the board, we are able to communicate with different providers as to when with this language, and it's like a uniformity for the patients who present with the lower extremity venous disease when we talk about SEEP. So the same thing they have tried to develop for patients who present with chronic pelvic pain. Although SEEP is very well utilized clinically in our day-to-day setting, SVP is a little tedious and requires advanced imaging. So this is more of a tool for research purposes and for recruiting patients in for trials. So the S stands for symptoms, V is for varices, and P is for pathophysiology. So they have divided the pelvic patients who present with chronic pelvic pain into 4 zones. Zone 1 involves the left renal vein. Zone 2 involves gonadal, meaning ovarian in females and spermatic or testicular in males, as well as the internal iliac veins and the pelvic venous plexus that arises from that. Zone 3 is pelvic origin extrapelvic veins, and zone 4 is lower extremity deep and superficial veins. So basically everything is based upon these zones, whether it's symptoms, the varices, and then of course the pathophysiology. The P stands for pathophysiology, which has 3 further subdomains, and the anatomy, the hemodynamics, and the etiology, A, H, and E. So symptoms, the S part, if there is no symptoms of pelvic venous disorder, it's called S0. If there is renal symptoms of venous origin, then it's coming from the first zone, which is zone 1, so S1. If there is chronic pelvic pain of venous origin, then it's coming from the second zone, so it's S2. Now, if there is renal symptoms and pelvic symptoms, then it'll be S12. S3 is extrapelvic symptoms of venous origin, and then the subscripts of A, B, and C. A is localized symptoms associated with veins of the external genitalia, so vulvar varicosities, scrotal varicosities. B is localized symptoms associated with pelvic origin non-saphenous veins of the leg. And then C stands for venous claudication. So we'll do some examples at the end of this talk, and then that will make it much easier to understand, and you can put things together. So the V stands for varices. Again, V0 is no abdominal pelvic or pelvic origin extra pelvic varices on clinical or imaging examination. V1 is varices arising from the renal hilum. So again, the first zone is the left renal vein or the renal vein and the IVC. So if there's varices arising there, then it's called V1. V2 is varices arising from the pelvic. So what you call the transpelvic collaterals or varices arising from the internal iliac vein. V3 is pelvic origin extrapelvic varices. And then again, the subscript A and B. A is for genital varices and B is the escape veins that we see. Now the the P part is the pathophysiology. The P stands for pathophysiology, and then again there is three parts to that, three subparts: A, H, and E. A is the anatomy, meaning which vessel is actually involved. It could be the IVC. The right common iliac vein is RCIV. Bilateral common iliac veins involvement is denoted as BCIV. Then external iliac veins, which could be left, right, or bilateral. Internal iliac vein again can be left, right, or bilateral, and then the pelvic escape veins, which are denoted as PELV. So that's the anatomy part. Hemodynamic is the reason of the presentation an obstruction, or is it a reflux? If it's obstructive pathology, then it's designated O, and if it's refluxive pathology, then it's designated R. And then the etiology, again, is it thrombotic, non-thrombotic, or congenital? So it's divided into three: thrombotic, meaning that this whole process is arising from a patient with previous history of DVT, so it's called T. Non-thrombotic it's a compressive pathology. There is no evidence of a DVT, so NT. And congenital is patient has congenital venous or mixed vascular malformation, so it's designated as C. So coming to these examples, this is a patient who has a CAT scan. On the A panel, it shows left renal vein compression. This patient presented with left flank pain and hematuria. So as I said, the CT demonstrates compression of the left renal vein, which is the white arrow over the abdominal aorta, which is the nice round structure lower down. And then this patient also had a venography, which again demonstrates attenuation of the contrast over the abdominal aorta. So where the left renal vein is getting compressed, there is poor filling of contrast, and that can designated as the black arrow. You can see that. And then the renal hilar varices is this white solid arrow. Because of the inability of the vein to drain out, you start developing all these collaterals. And then there's the ascending collateral, which is the broken arrow. So based on this, the SVP classification for this patient will be S1, because these symptoms are only renal associated, flank pain and hematuria. V1 is varices in the left renal vein, so it's V, that's why it's V1. As far as the pathophysiology, what is the anatomy? This is the left renal vein, which is being involved, so LRV. What is the hemodynamics? This is an obstructive nutcracker phenomenon, so O, and this is a non-thrombotic, what you call presentation. It's patients did not have any evidence of DVT, so it's NT. So the complete classification for this patient is S1, B1, P, LRV, O, NT. So there's another example of a patient who presented with chronic pelvic pain. And this is a venogram of the left iliofemoral venous system, which we'll go over that. So this other information on this patient, the patient has no lower extremity symptoms. The transabdominal ultrasound, which is not present, has not been shown, demonstrated greater than 50% compression of the left common iliac vein with retrograde flow in the left internal iliac vein and periuterine varices. The IVUS, again, which is not shown here, demonstrates 70% cross-sectional area reduction of the left common iliac vein and the crossing of the right common iliac artery, so a patient of May-Turner syndrome. So this is antegrade venography. It demonstrates flattening of the left common iliac vein with contrast attenuation at the arterial crossing, which is the black arrow, so what we call the pancaking effect. And also there's reflux in the left internal iliac vein, which is shown as the white arrow. And although we are not able to see the transpelvic collaterals, but they said with delayed imaging, there was pelvic varices, which are seen arising from the internal iliac vein. So we do the SVP classification for this patient. The patient only had chronic pelvic pain, so it's the second zone. So the symptoms will be S2. Excuse me. The varices are again arising from the hypogastric vein and the internal iliac vein crossover varices. We don't see them here, but that's what they say in the vignette. So V2. Now coming to the pathophysiology, we divided into which vessels are getting affected. The left common iliac vein is the one which is clearly being affected. You see that the contrast attenuation and the flattening. So it'll be LCIV, and that's the anatomy. What is the hemodynamics? Is it obstructive or is it reflux? There is clearly obstruction here. So it's O and it's non-thrombotic, so NT. Now we also have to mention what's going on in the internal iliac vein. So there is reflux, so IIV is involved, L left internal iliac vein is involved. There is reflux noted, so that's the hemodynamic in this internal iliac vein is so R, and then again it's where is the reflux coming from because of a non-thrombotic physiology upstream, so it's NT. So the complete classification for this patient SVP classification will be S2, V2, P, LCIV, ONT, LIIV, RNT. Now, what do you do with this? I don't know. Anyway, so this is the end of my presentation. We can take questions.
So, come on. So thank you, Gaurav. That was, as usual, very comprehensive. Is there any questions for Dr. Lakhanpal? So let me see if I can change the view here a little bit.
And there are more examples in the SVP paper, which was published. So it'll be a good idea if you want to practice. I think it's more of a board thing for you guys. We may give you clinical vignettes and ask board questions on the SVP classification. I don't know, Dr. Pappas, what do you think? It's probably more board related than anything else.
Yeah, for now, and I think the classification system, they're trying to encourage people to use it in publications. You know, I think right now it's more of a research tool than it is a clinical tool, just so that when we're doing studies, we can communicate our findings, you know, to people. So I don't know. So one of the things that struck me during your presentation is that 10 to 15% of patients can have multiple pathologic processes occurring at the same time. So you can have somebody who's got pelvic venous insufficiency and still have endometriosis or a fibroid or something else. So I think the point that you made about making sure that they have a gynecologic evaluation is one of the take-home messages. But even if they do find something that's gynecologic, it doesn't mean that the pelvic veins are not somewhat involved in it. It's just more to explain to the patients about expectations of what their outcomes could be if you do treat their pelvic venous insufficiency, but still leave, say, their endometriosis behind or something like that.
Yep, absolutely. And we see actually, you know, we've started getting patients from people who have been seeing this pelvic floor therapy specialists and also chronic pelvic pain specialists who treat all these myofascial trigger points and all that stuff. And I am very upfront with them that I don't know. Yes, we see compression. I don't know how much of this is going to improve. You know, so because I've seen is, you know, with our practice since we've been doing this since 2014. You know, even before that maybe 50% improvement may happen in their symptoms, but they will still have residual 50% issues going on. So we have to be really, really upfront and tell them that this is not an end all and cure all for your symptoms, especially for people who've been struggling with this for over a decade and have undergone all kinds of stuff, including hysterectomies, oophorectomies, you know, what do you call Botox injections in their bladder, et cetera, et cetera, et cetera. So the list goes on and on and on. So I'm getting very, very reluctant to try to do stenting for these, because that's the last thing you want, and adding another thing for their more in their mind that, oh, I have a stent now. Is that what is causing it? So
yeah, we've seen we're starting to see a lot more referrals from the pelvic floor therapists as well. I have a little bit of a different view on it. I think the majority of the patients who I've treated have done well, and they've been very, very happy with it. I think right now, anecdotally, it's only been a handful of patients that haven't seen a tremendous amount of improvement, but they see some, but not a lot. I think what's difficult is those patients whose symptoms may be anxiety or psychologic related. So you have to be really, really careful. I think it's what your point is, patient selection in this group is important.
Yep.
And you have
Yep.
to feel pretty
Very important.
confident that a component of what they're experiencing is circulation related. So, but you're right. I think it's another group of patients that we kind of don't know a whole lot about, but maybe that'll be our next research project, is to look at some of these pelvic floor patients and try to sort out which one of them would benefit and which one of them may not.
Yep.
All right, anybody have any questions for Dr. G? All right, very good. Have a good weekend, everyone.
Thank you.